Hope everyone's enjoying the session so far. I'm Osami Honjo, one of the surgeons in sick kids. So I'm just going to demonstrate a slightly different technique, which we call it a closed technique. I believe this is originally developed by Dr. Bove in Michigan. We have been sort of using this technique probably from 2000 range and quite reproducible. So we do the aortic and bicaval cannulations. I tend to cannulate the proximal aortic arch so that we have whole ascending aorta to work with, and standard bicaval cannulations. When we go on bypass, we do two things. One is to ligate the PDA. So we used to divide the PDA before arresting a heart, but we found that quite easy when we arrest the heart. So we just ligate the aortic end when we're on a bypass. And then the next thing we do is put a LV vent through close to the right upper pulmonary vein. Here, we try not to put the pursing on the vein, but rather on the left atrium. So that's the two things that we do before arresting the heart. Then once we're ready to arrest the heart, we place the cardioplegia needle without placing the pursing stitch, because that's where we're gonna transect the aorta. So so the incision point is exactly the same as Dr. Varm mentioned, which is about 5-6 millimeter above the sinotubular junction, so way above the coronary ostia. It's important to be high in terms of incision, because sometimes you have a surprisingly high coronary takeoff. So let's say you put about here. So press the cardioplegia site, and then the assistant is going to hold the ascending aorta and then cardioplegia while giving antegrade cardioplegia. And then the surgeon open the right atrium to decompress. And as I said, we place the LV vent here. That's mainly for the dearing when we are on a bypass on beating. I usually place an extra sucker across the PFO just to be completely dry. So that is set up, and then so this is a cardioplegia site. I cut across the cardioplegia site about 1/3, and use a little instrument to look down. So make sure there's nothing surprising. So if anything, well, like undiagnosed intramural, you will see something wrong with this posterior commissure area. So make sure there's nothing there. Then we're going to transect. So it's important.
You can tilt
sure.
for the camera.
Yeah. Okay. So it's important that your assistant have exactly the same tension as your left hand. Otherwise, they're going to cut not straight, right? So, and cut both sides and transect here. And if there's any tissue, we just clean up at that area. And 6.
What do you use?
What stage? Okay. So space suture, we put 2 instead of 3. So when you start doing that, you can decide however you want it, but we'll just do 1 straight anterior. So we do partial thickness in a real case, but this one we may have to do a full thickness just to, yeah, yes, we have to. Okay, hopefully that stays. Okay. Can I use it twice? Okay.
You want a rope shot?
Sure. Okay. And, this is kind of a direct anterior. And then the other one is directly above the posterior commissure, which is right there. Okay. So the next phase, which is very important, so just put both retraction anterior, and then you can go here and here, sort of like this. Yeah. So here is opportunity to dissect this plane between the great vessels. I use the artery. You want to lower down the artery so that you're not going to burn the coronary itself. So just kind of mobilize here until you see the plane between the great vessel nicely. And then here's also the opportunity to look at the course of the circumflex coronary artery, how how close to your narrow aortic root. So we'll do that here, and then when you're happy, when you see kind of a separation of both great vessels, then start taking down the coronary buttons. So the principle of taking coronary button is exactly the same as open technique. So you have to take down the whole sinus. That's I cut a little higher on ascending aorta, but that's okay. So straight down. So I take down the left first. So once cut a little bit, so I just move these two things, moving things around. Oops. So I can grab there and then maybe here. Yeah. So and then as Dr. Barron said, it's important your scissors aiming towards the commissure, right? Because this is neonatal tissues tend to sort of shrink as you cut. So if you think you're cutting straight, you actually it can be very close to the coronary ostia. So what I'm trying to say is that this scissors angles is always towards the commissure. So if you make a mistake and you cut something important, that should be the pulmonary valve rather than your coronary ostium. And once I get down to this bottom, I look at one thing, which is you can negotiate how much you take for the bottom and then how much you leave for the neopulmonary artery. Obviously, if you have a little bit of neopulmonary tissue, it's easier to reconstruct the PA, but obviously you want to leave as much tissue to the coronary bottom as well. So it's a negotiation. Again, coronary bottom is the most important structure. So if you don't have enough space, you leave enough space for the tissue for the coronary buttons, and then so you can see a little bit of relax, just a little less tension. Yeah, so you can see a little bit of neopulmonary artery. So this is where you're going to use for the reconstruction. And then so this is kind of halfway there, and then I stop and then go from the other side. Okay, just hold like that. Yeah. So here, one thing you want to do is to cut obliquely. So obviously from here to there is the only native neo PA that's going to grow, right? So in other words, you don't want to cut this way. You want to cut this way so that you have relatively narrow top of the coronary, because here most likely you're not going to use it for the reconstruction, but rather you leave enough tissue for the pulmonary artery growth in the future. The one thing I forgot to mention, so this is a very centric coronary ostia, but sometimes, or oftentimes, you have eccentric coronary ostia. Oftentimes, this ostium is very close to the posterior commissure. In that case, you still want to have this much coronary button in order to sew safely. So in that case, we use the 15-blade scalpel and then take down some of this commissure to make more room for the buttons. But this one, we don't need to do it because this is very eccentric. Okay, so just aim. Let's pull up this way, yeah. Okay, this way. I cut a little too close to the coronary. And then here it's important to go inside of the vessel. Okay, and now I use a cautery to take down, so kind of buzz the aortic wall to separate them. And here, so either the left or right, you have one anterior branches. Just pay attention to that. That sometimes hugs the original aortic root. And then you want to keep that. And then in order to mobilize, I sometimes use the little mosquito. So they say if you have anterior branch, I just pass through behind it. Just make sure you have mobilized very well. And I think, so compared to Dr. Barron's way, I probably mobilize a little more, like 1 or 2 millimeter more distal to make sure we have enough mobilization. And so this tissue sort of between the neo-aortic root and coronary, between the circumflexion and neo-aortic root, sometimes there's kind of stuck, so just mobilize there. So let's see. And yeah, so this one needs more mobilization, my view. And as I said, there's an anterior branch, or sometimes this one trifurcate with the LAD, intermediate, and then circ, and then just pass through the mosquito carefully. Obviously, you don't want to make a hole there, but there we go. So that should be enough. Relax. Yeah, yeah, that should be enough. Okay. So I always do left first. I don't know why. I think doing the right, maybe easier. So you just have to find a way. And this is one of the most important part of the operation. So you want to take time. You don't want to rush. Yeah. Okay. Yeah. So again, so before you cut it out, you want to see where's the coronary ostium is, right? This is quite centric as well. So you don't need to take down the commissure. So sometimes you have to take down this anterior commissure if this one is too anterior. Straight down and make sure this scissors tip is tilting towards the commissure rather than ostium. Okay. Yeah, so this is more than enough button, so just gonna go down this way. I usually stop at halfway, right at the bottom of the button, and then start it from, yeah. And again, you want to leave as much as possible on an anterior wall where a PA grows. So we just can push here. Is that possible? Yeah, perfect. Okay, so again, if you have anterior branch, sometimes it comes here. So you really want to make sure you're inside of the vessel. Yeah. Okay. That's good. Again, let's switch to artery, electric artery to mobilize. And typically, I just pass through the mosquito between the anterior branch and the main right. The other thing to notice that you most likely you have a small sinus node branch coming off around here. Right? Obviously, you want to preserve. And then usually there's a lot of tissue posteriorly around here, so that's something you want to mobilize. Okay. Yeah, so that's about right. Okay. So at this point, just put both retraction anteriorly so that we can look at.
Do you want mosquito just to show it? Just to show it how to do mosquito.
Oh yeah, yeah. So if you have to, so it's like this. To pass through. Let's say you're making a hole here, so it's pass through very gently, like this, like say here, and then you can actually see through it like this, and then pass through. There's some risk of bleeding from the myocardial surface, so just be careful. And then at this point, what I usually do is to get the assistant to hold like this, so it's pass around the narrow aortic valve. So this is the opportunity to suture ligate. So as I said, when we on bypass, I just ligate the aortic end. And then this point, I just ligate the PA end. And then before cutting out, just suture ligate with 6 on both sides. Let's say we did that, and then we divide. And then in the same move, just gonna divide the PA, right? So the most important landmark is the origin of the right PA, which is a bit difficult sometimes. So obviously, just analyze the narrow aorta. So you can see the sinotubular junction. You can see it right here. And then this is the origin of right PA. So again, you want to have as long narrow aortic root as possible. So if you're going to sacrifice, it's going to be a branch PA, not your commissure of the narrow aortic valve. Right? So yeah.
You want me to hold
Yeah,
this?
yeah, just gently. So yeah, so this switch, the first 20-25 minutes, you're only cutting, you're not sewing, but there are a lot of the things can go wrong. So when you're cutting, you really have to think about, what is the most important structure you have to save out of 3 3, and then you can compromise, the structure you can compromise here. Top of the commissure of the narrow aortic valve is the most important structure, and then origin of the right coronary is the second important. So we're just kind of cut it here, roughly, and look down. Look down 2 things. Origin of the right. So I'm a bit too close here, but it should be okay. And then posterior commissure. So we are quite away. And cut evenly. Yeah. There we go. At this point, to avoid the backflow, we put a vascular vessel loop around both PAs, and then snap it with vascular clip so that there's no backflow there. Okay, so and then at that point, we just mobilize the whole PA and do the loop count before we forget. Yeah, and then so here, because this anterior aorta becomes really posterior, so almost always is redundant. So we'll go ahead and then cut a little bit. Let's shorten the aorta. There we go. Okay. If you have a question, just talk to the microphone. Okay. It's better to put it in something.
Do you want to stay straight?
Yeah, I'm just gonna stitch it. Where is your needle box? No needle box?
I mean, what's here?
Okay. Don't get caught.
No.
Yeah. So I sometimes put a little forceps tie. And just tie it here.
Dude, I can't handle it later, please.
Okay, so here's what I demonstrated so far is quite similar to the open technique, and then from now it's quite different. So I just showed. So we did look count. Obviously, before that, you want to make sure that the whole branches were mobilized. I shorten the aorta here, and then so from now on, this is quite different because obviously you want to solve the coronary in a closed manner. Okay, so using a small, so we use a 5/0 self stitch, but for the convenience, I'm using a 6/0 prime today. But we'll mark the commissure. The most important thing is obviously the anterior commissure. And then I usually take like not even 1 millimeter, slightly above the commissures to be safe. Because one of the things that's this technique is important is that we're cutting the aorta blindly. So we really want to make sure that you're not cutting the aortic valve. So this is the anterior commissure marking. So whatever cutting above this should be safe. There's no narrow aortic valve here. And we'll look to see if we have to mark other commissure as well. If there's no commissure malalignment, you don't usually mark it, but so here's, can you okay? Okay, I'm just gonna show the neoaortic valve. So this anterior commissure is marked, and I don't think those two posterior commissures near close to the coronary artery, so we're not gonna mark it this time. But if there's a commissure malalignment, usually you need the two markings. Okay. So at this point, we're gonna go ahead and sew the coronary together. Yes. So we only saw the half, and then I will switch the suture, and I will tell you why. Yeah. Okay, so in my experience, this anastomosis bleed the most, just because almost always your male aortic root is bigger than the distal ascending aorta, particularly when you shorten the aorta. Therefore, you have to make up the size discrepancy. Okay. Maybe just go over here. Let me close this.
They're closing it just like. Okay, just a second.
Yeah. And
You want me to pull up?
yeah. Can you see the aorta on the camera? Yeah.
Everyone is there.
No, but can you see on the camera?
I think the coronary is
Coronary.
closing it, yeah.
Um,
Bottoms are closing.
let's see.
Yeah.
Okay. All right. So this is just a regular aortic anastomosis, but as I said, almost always your male aortic root is bigger than the distal ascending, so you really have to make up proportionally. You really don't want to make up everything on the anterior wall. So by the way, if we have a ventricular septal defect, I usually close in this point. I know Dr. Byron closed at the beginning, so I think you can close in any timing, but better to be consistent every time. Okay. The silicone, very good. Okay, relax. Okay, so now we look. So what we're looking at is left corner. So roughly where this is gonna go. So the key is that this one frequently go across the aortic suture line. Right, so that's why we want to use two separate sutures. So here, but this one definitely gonna be above this suture line, close to this. Okay. So we just kind of look at where that's gonna go. Are we running out of time?
No, time has
What
stopped.
time is it? No, what time is now? Okay.
It's inside.
Okay.
The inside of the person.
Yeah.
Yeah.
Okay.
Okay.
Stop here. Just one more here. Okay. Come on.
Mm-hmm.
So I just stop here, so where the coronary probably is going to cross. And so up the other side. I can look at the aorta. So this one just so kind of 3-4 stitches, and then it comes to the area that left coronary this time. Might cross the suture line. We're just gonna evaluate in a minute. Okay. Yeah. You can look complete it. I see much stops. Okay. Okay. Just let that go. Let's see if so just roughly. So this one looks like, can you see? Yeah, this one looks like it doesn't cross it. It's really okay. Yeah. Yeah, so this is a suture line, and this is a coronary. Looks like it's gonna be in the sinus. So for the sake of this method, so but this is roughly where it's gonna cross. So start a new one. And obviously you don't want to cross a suture because that's where you want to cut across if you needed to. And put a shot there. You have a new shot. Or you can put a shot together actually. Yeah.
With this one?
Yeah. And just finish the aortic anastomosis. So here you can go very quick because it's by the time it's quite much there, and it's very easy to repair if you have a little bleeding. So okay. And this is where we left with. And as I said, the proximal part is a little bigger, so we just keep matching. So let's advance on the distal part, more advance on the proximal. Okay. And so we get close to it, but you don't want to cross this suture line, so that so you want to cut here if you need to. Okay, so at this point, so we complete the anastomosis. So with a little bit of dearings from suture line, we actually take out the cross clamp. So that's gonna inflate the aortic root as it is. And then also we kind of detension can grab here. So we just hold this neopromite root where that's gonna be, and then we'll determine the location. So this one looks like it's gonna come very low, right there. Can you see on the camera? Yeah. And then this right one, it's gonna come pretty high, I think. Right about here. Okay. So what I usually do is just put the marking here and then I cut here. I don't have a knife.
Do you want escape?
Oh, perfect. Thank you. Okay. So, can go up here, gently. So as I said, this at that point, aortic cross clamp is out. So this vessel is pressurized completely, and then this is the top of the aortic valve. So we are pretty safe. And then based on the assessment, it's going to be somewhere around here. Okay. And that's enough because it's going to be blood all over. And then relax.
Do you want cuts?
Eventually, yeah. And then this side.
Mm-hmm.
So this is very close to the commissure. That's why it's very important to mark it straight up. Okay. And now, and then put the cross clamp back on so that you can actually see it. And so this is a medial trapdoor. Okay. I think I have this left corner. Yeah, perfect. So it doesn't have to be super big. In fact, you don't want to make it too big. That should be enough. And so this whole sort of a bottom has to be slightly smaller than this length. If it's longer than the coronary button, then that's gonna flatten the coronary button, which is not good. And the top part you don't need a lot. Okay, so that's the setup. And so once we got the setup on the left coronary, we're just gonna start sewing. So this is the advantage of looking at the different surgeon sewing. So I just start from the bottom. I think this both have advantage there. So just for this one, to make sure that your orientation of the bottom is right. So this bottom matches to this corner. And then usually it takes 5 to 6 bites on the bottom. Okay, follow. With your right hand. Yeah, relax this. Yeah, that's perfect. Okay, follow with the right hand. And then just grab here.
Yeah.
So make sure you're away from the coronary ostium. You really don't want to have a tension on the ostium itself. Okay. We're about halfway on both sides. Yeah. And you really want to make sure this corner of the coronary ostium, coronary button matches the corner of your trapdoor, medial trapdoor. So we're almost there. This is the corner, I see. Okay. So far, I'm showing my position is just kind of cross from the aortic root, but at this point, I just kind of come to the patient right shoulder and then saw from the top, so that I can keep looking at the orifice. So the shoulder. Like this, you can see the orifice here while you're sewing it, so that you're not going to be too close. And then sure. Yeah. Right. Okay. So here we start advancing a little bit on the aortic wall. Okay, this is a chopped out part. And again, make sure your assistant have a similar tension all the time, because in neonatal tissue is very stretchy. So if you don't pay attention to, sometimes tissue is overstretched. So we're almost at the top of the medial. Okay. And then we never cut this redundant button at the top. This is very convenient to grab it safely. Okay. That's at the top of the button. Okay. Darker than the beginning, huh? I don't know why. Yeah. Okay. Yes.
I think it's one of the benefits of this technique. I like the idea that you can fill the aorta and the aorta is in its natural position before you reimplant the coronary, so you really get a good feel for how it's going to look when the aorta is full. I've seen there's a sort of another kind of mixture technique I've seen where you can do the Lecomte maneuver first, like this, but you still do it open, but you do the back wall of the aorta first to kind of straighten up the aorta so you've got it lying in its natural position, but you don't come around anteriorly, and then you make your trapdoors through the sinotubular junction.
Okay. Okay. Yeah. So we're pretty much okay. So this lateral side is very straight. Okay, so that's the comb. So I just get to the top. At this point, we just kind of cut the redundant aortic tissue. Oops, sorry. Can go here.
Yeah.
Yeah. Usually you need a little more length on the medial side. I just aiming like this. This one little oblique. Okay. And finish up. Okay, so all right, so that's that. I'm just going to show you the. Yeah. something like this. And the right side, we made an incision, right? Yeah, right here. So that's the right side. And oftentimes, this both coronary try to sort of get too close, almost kissing each other. So we try to avoid that. So tendency is make it incision very close together, but nice to have some distance in the middle. Okay. I guess we should.
Yeah, should we
Yeah.
stop so we
Yeah.
can get going?
All right. Any questions from our attendees?
Just one question. With this close technique, at what stage do you close the AST?
AST.
Yeah. What stage do you close it? Like before releasing the clamp, like at stage of the operation?
Yeah, that's right. So let's say, in case of TGA intact septum, you just have AST. When we complete the both coronary buttons, then we just close the AST and then take a cross clamp off. So I do the PA reconstruction while the heart is beating and rewarming. But you just heard that Dr. Barron does the PA reconstruction.
I put the patch in to repair the coronary button defects while my cross clamp is still on, but then I do the pulmonary artery reconstruction to the branches, the LeCompte, with a clamp off. Yeah, the ASD is the last thing you do to close before you get your cross clamp off. So whichever order you do things in.
Back to the coronary mobilization that you started with. So you mentioned about the anterior branches from the coronaries that sometimes go onto the anterior surface of the right or the left ventricle. So how do you feel about sacrificing them? I mean, just cut them with cautery, and that helps with mobilization. Of course, there will be some myocardial ischemia with probable ECG changes, but how do you feel about sacrificing those small branches?
Well, I'll go first. Majority of cases, you don't need to sacrifice. And in fact, I actually like to have that third branch, because that makes the coronary transfer position, almost like a one position. If you have very, flappy coronary, let's say you only have LAD and then nothing else, you can go almost anywhere. But you have an anterior branch and left main LAD circ, you only have one good place to go, and then that really makes your position easier. And then mobilization purpose, you actually don't need to sacrifice.
Yeah. No, I agree. I think if you can, it is often a very small branch, but it's still, you want to try and preserve it if you can. And as Sami was saying, they're almost like little guy ropes on a tent holding the coronary button in a good orientation. So I try and keep them if I can. As Osami said, you can sort of go underneath it with a little mosquito and free up the tissue, so it's got a bit more mobility. But you don't usually need to sacrifice it. If you really had to, I'd probably more likely actually oversert with a lato prolene and then divide it rather than rely on cautery. But I'm sure you could sacrifice it. You would have a very small area that was a bit of, where you lost the coronary blood flow, but it would be a tiny area, so it wouldn't be unforgivable. But try and keep it if you can. Okay.
One more.
Yeah, another question? More questions?
Go ahead.
Go ahead.
No, Dr. Barron, do you find it helpful to put marking stitches beforehand going on to bypass on the patient, denoting where your potential coronary injury?
I don't personally find it helpful, but I know a lot of people do, and I think it suits. It just depends, how comfortable you feel. My only concern is sometimes if the marking suture's there before you start, it might not quite exactly be where you want to put the coronary once you've actually taken the coronary out. And I like the coronary to tell me where it wants to go once it's been taken out. So, but I think some people do find it helpful. So I think you don't have to decide whether you find it useful or not. Personally, I don't use it.
Okay, thanks.
Yeah, in a closed technique, we don't at all. Actually, the optimal place is you really never know until you completely take down the coronary and then mobilize it. Right? So sometimes you have little supplies, how stuck the coronary or sometimes it's very mobile, and then you have to think about it. So before going on bypass, in a closed technique, we have no idea where it's gonna go.
Okay, so great.